Hi, everyone. Welcome to today's session of Healthy Discussions. Before we get started, I'm just going to share a few housekeeping notes. The chat box and the Q&A feature are both open, so please feel free to use them. You can turn on subtitles, which are auto-generated by clicking the CC button on the bottom left corner of your screen. And this session is being recorded and will be posted to Quality of Care NL's YouTube channel a little later. I'd like to acknowledge that we're joining you from the ancestral territory of the Beothuk, and the lands on which Memorial University's campuses are situated are in the traditional territories of diverse Indigenous groups. We acknowledge with respect the histories and cultures of the Beothuk, Mi'kmaq, Innu, and Inuit of this province. We also invite everyone to offer land or territorial acknowledgements in the chat and to take a moment to reflect not only on why we offer these acknowledgements, but also ways your life and work may contribute to decolonization and reconciliation. For those who aren't familiar with Quality of Care NL, we're a research and evaluation program based at Memorial University, aimed at improving social and health outcomes in our province. Healthy Discussions is a webinar series where we have quality conversations about health, healthcare, and social systems in Newfoundland and Labrador. Our goal is to engage with you on these topics with the aim of continuing public conversations during the ongoing process of health transformation in our province. Public discussion also contributes to the growth of a learning, health, and social system in Newfoundland and Labrador. On the screen right now, you can see a definition of a learning, health, and social system as defined by Health Accord NL in its task force report. This definition might seem complicated the first time you read it, but what it really boils down to is a health and social system that continuously improves through a culture of best practice, evaluation, equity, openness, and collaboration. The system learns and gets better, which results in better care and health for all. Part of the definition states that individuals and families are active participants in all elements, and by engaging in sessions like this one, by being an active participant in your own healthcare and wellness, and by talking about and acting on issues that impact us as a society, you are contributing to a learning, health, and social system in our province. Today, our discussion will focus on the topic of social prescribing. We're delighted to have joining us three panelists today. First is Srija Biswas, Project Manager with the Canadian Institute for Social Prescribing, Suzanne Brake from Seniors NL, and Dr. Jane Gazain, Professor at Memorial School of Music and cross-appointed to the Faculty of Medicine. Joining them for today's discussion is Quality of Care NL Manager Robert Wilson. Robert has some questions to get our conversation started, but we will be taking questions from the audience throughout. You can type your questions in the Q&A box, which is a little easier for us to manage. Sometimes questions can get lost in the chat as people chime in with their thoughts. And lastly, since today's discussion is being recorded, you may wish to ask your question anonymously, which you can do by using the Q&A instead of the chat. So without any further ado, I'm going to pass it over to Robert to get started with our discussion.
Thanks, Melissa, and thanks for our guests for joining us on today's important topic. So I'm going to start off with a few questions. I'm going to start with you, Srija, right off the bat. I'm going to ask you to describe what social prescribing is and how does it work and who is it for?
Thanks, Robert, and thank you for that warm introduction. So social prescribing is a model that enables healthcare providers and professionals in the social and community services to connect individuals with non-clinical supports and community resources. And these resources can address individual and community needs, which results in social and emotional well-being, and all through in a more integrated healthcare system. And social prescribing is basically a way for trusted individuals in clinical and community settings to identify that there is a person who has some non-medical needs and those non-medical needs are contributing to some sort of health need, and then subsequently connecting them to supports and services that are non-clinical within their community, by co-creating a social prescription with them. And at the very core of social prescribing is person-centeredness. What that means is that it prioritizes individuals' ability to determine their own goals and strengths and take control of their well-being in a supported pathway. So really, to shift the focus from what is the matter with you and looking more at what matters to you and making sure that when we're creating a prescription, it reflects what matters most to that individual. And as for like a social prescribing pathway, I am sure that all of you have been part of a social prescribing pathway. You are implementing some sort of social prescription in your area of work. There are many ways social prescribing is taking place in Canada, but generally there is a pathway that includes four main components. So the first component, as I said before, is to identify that there is an individual or a family who is experiencing some sort of non-medical needs, which contributes to their health and well-being. And this identifier can be a primary care provider, or can be a community leader, or any other secondary care provider, but also can be a family member or a friend, or even someone themselves identifying that, hey, maybe I can benefit from some sort of extra support that can contribute to my health overall. So yeah, it's all that to say is that there is no one door that's the right door. There are many doors that can be the right door for you. So once that person is identified, then they can be connected to a community connector or a link worker who is basically going to explore what the person's strengths and goals are, and then co-create a solution that matters most to that individual. And then that link worker also journeys along with that person while they participate in those solutions. And these solutions can look like so many different things. It could be something very simple as, hey, maybe you should go out more in the park for regular walks. Or it could be something like joining a music group or joining your local community organizations. Anything that really matters to that individual. And one of the key components of social prescribing is just the whole tracking and making sure that, yes, these individuals are joining these programs and initiatives, but how are they actually impacting their overall health? What are the outcomes of these participations? And then feeding it back to the identifier point of contact, if that's possible. So really, social prescribing can be for anyone, ranging from older adults to even children, anyone who is experiencing a social non-medical need that is affecting their health and has unique strengths and interests. So yeah, I hope I was able to answer your question about social
You were.
prescribing.
So, I mean, just to, before I get on to the next question, you could perhaps say that social prescribing has existed. It just really hasn't had a particular label on it, calling it so like a actual prescription. Just moving on to another question for you, Shrija. Can you kind of give us a snapshot of what social prescribing looks like in Canada and perhaps give examples of some initiatives or programs happening across the country?
Yeah, so social prescribing has been ranging from provincial initiatives to hyper local like local projects, varying in sizes, approaches, target population, tailored to different community needs. There are different sorts of social prescribing initiatives. So if I have to do like a geographical scan of what has been happening for social prescribing in Canada. Maybe I would like to start with BC. I would like to say that so their social prescribing initiatives are funded by their ministry, managed by United Way BC. Starting in 2020, they have been implementing programs across over 20 communities to connect older adults back to community resources. And BC has dedicated link workers that are funded through their ministry, working in connection with healthcare providers to connect individuals to community resources and also tracking health outcomes. And then there's Alberta. Alberta is doing a lot of social prescribing implementation through Healthy Aging Alberta. They have been taking on a 3-year social prescribing initiative for communities while also creating lots of resources around training, around the role clarity for link worker and other tools to support future implementation initiatives in Alberta and across the country. Then we have Saskatchewan. Saskatchewan Seniors Mechanism is leading some really, really cool early stage work in terms of social prescribing, which includes implementation to some pilot sites and creating trainings and knowledge translation opportunities. Manitoba Association for Senior Center is also doing some social prescribing implementation in connection with their communities and healthcare providers. In Ontario, there are a lot of work happening with leadership from Alliance for Healthier Communities and Older Adult Center Association, so OACAO. They have been implementing some social prescribing in collaboration with community health centers in Ontario. So basically in connection with the primary care providers and the non-clinical supports and services. I think they're right now implementing across 28 sites. And there are some really cool initiatives happening in the Atlantic provinces. And but I think Suzanne will be the expert to share more on what's happening in the Newfoundland. So yeah, all that to say that there's so much work that's happening. There are work happening around implementation with the communities, implementation in connection with the primary care providers, while also making sure that we're working on building the infrastructure. We're also working on building the resources and tools that we will need to support future implementations.
Perfect, thank you. So Jane, I'm going to turn it over to you. Srija obviously gave us an excellent example and snapshot of what's happening across the country, but perhaps you can enlighten us on what's happening globally.
Yeah, thank you. Well, as you mentioned, Robert, that the idea of social prescribing has already existed in many different ways, drawing on different practices in healthcare. But it originated in the sort of way in which we think of it now in the UK in the late 1980s and early 1990s. And the first program was established in an area of London with high levels of poverty and significant health problems. More recently, social prescribing has become embedded within the UK's National Health Service, where it's a key component of universal personalised care, and it's part of the National Health Service long-term plan. So currently there are over 3,500 link workers across England. And according to the National Social Prescribing Academy recently, more than 2.5 million patients have been referred to link workers. And the goal is that every GP practice will have access to a link worker to address things like issues around health inequalities, supporting the social determinants of health, and reducing pressure on GP workloads. The UK's approach to social prescribing tends to be used as a model or a reference point for social prescribing, mainly because it's been in existence for the longest. But even within the UK, there's a huge diversity within that model, depending on the local area, the type of population, and so on. So you can't really generalize about what social prescribing is. So similar to what Srija was saying around what's going on in Canada, there's a great variety of different things. Last year, in a joint publication by the Global Social Prescribing Alliance, WHO, and the National Academy for Social Prescribing, authors from around the world outlined briefly the state of social prescribing in 24 different countries. And this is a really useful document if you're interested in global aspects of social prescribing, because it really gives a broader perspective on how social prescribing is being implemented in different places. Just to give sort of some ideas from the work that's being outlined in that particular document, as well as other documents at the moment, it's important to remember the sort of obvious, which is that each country has its own approach to health policies, priorities, and needs. Some countries have centralized systems, others decentralized, with both funding and governance spread across national, regional, and municipal levels. And that's going to have a huge impact on how social prescribing fits into healthcare. So again, we have to be wary when we're looking at different practices from places, how we use that when we want to have a better understanding of what's going on in Canada, or our ideas of what we want to bring into effect. The most common model is the one that Srija was mentioning, with the idea that you have a trusted individual, whoever that might be, who's making a referral. And we often use the terms link worker. That's the term that we're using in Newfoundland and Labrador. It's the one that's most commonly used in the UK, but you might also see references to community or social connector, community and a social navigator, well-being coordinator, well-being coach. They're all commonly used. To add a little bit to the confusion that those terms are also used for other things that aren't to do with social prescribing. So again, we have to be careful when we're reading the literature in order to interpret it really well. In some places, the role of the link worker is taken by existing staff, so social workers, allied health professionals, nurses, physicians, and sometimes volunteers. And in other places, they're newly formed, and so they're hired specifically as link workers with new funding used to support that. In some places, the link workers are based within hospitals, others they're in community centres, some they're in GP practices. So there's a diversity there in the way in which they're hired and the place where they're located. And one interesting thing, in Japan, there's a program where they're connecting people within hospitals to community services. And also in Japan in 2021, there was the first Minister of Loneliness and Isolation to address the rising incidence of suicide and mental health problems. And that ties in really well with some of the goals of social prescribing. So that's one model that's being used in Japan. One other aspect of how different countries sort of use social prescribing relates to training. That different countries have a different idea about how link workers are trained. For example, in the Netherlands, social workers can receive additional training to work as link workers. In Spain, physicians receive additional training, and they're really important in the role of social prescribing. Since in Canada we have such a problem with numbers of family physicians, I certainly wouldn't be advocating for family physicians to be taking on that additional role. I would be advocating for specific link workers. In the National Health Service in the UK, link workers can train using different modules, and so they have a training from that. Similarly, in Iran and in Singapore, there's a strong focus on social prescribing within medical schools, so that physicians are learning about social prescribing as part of their medical training. There are some peer help sort of for medical students in the UK, so champions there who help medical students. And within Canada, we have the Canadian Institute of Social Prescribing student collectives, and there's one in Newfoundland and Labrador, where students are really active in promoting and learning about social prescribing. And MUN's Faculty of Medicine also has a student interest group. So there's training is occurring in all sorts of different ways at different levels. Just a couple more points sort of about different countries is a way in which referrals take place. For example, in some places in the UK, it's integrated and there's access within electronic medical records. So a physician has immediate access to some of the community programming that might be available in particular areas, and that's then available to some of the link workers. Some of the countries focus on target populations. So in Singapore, there's a lot of emphasis on seniors. In Korea, I think I was reading about some of the emphasis on mental health. In Taiwan, there's an emphasis on dementia. And as Shrija mentioned, within Canada and certainly within the UK, it's right across the lifespan from babies through to end of life programming. So I think I'll stop there with a quick overview. I could keep going, and I know I shouldn't, so I will stop and let you move on to the next question.
Well, before I go on to the next question, I just want to ask see if you could give us a quick definition, because this term has come up a few times. Shrija has mentioned it, and you've mentioned it many times throughout as you went through the global examples, is a link worker. Can you kind of give it a quick definition of what a link worker is for people who perhaps don't know that term?
Do you want to do that, Shrija?
Yeah, I can start. And Jane, I would love to hear your thoughts, and Suzanne as well, from Newfoundland perspective. So a link worker is basically someone who understands, who has a good sense of what's out there in the community. So who understands what resources out there in the community. A link worker is someone who knows how to have an exploratory conversation with a client to understand what matters to that client, what are their social needs, and how that can contribute to their health need. So it's a combination of couple of skills. And what we see is a lot of the time a social worker assumes the role of the link worker. And sometimes we see that there are some link worker training guides that are being generated right now, where we're seeing some really core competencies around what a link worker role can offer and what kind of trainings we need to have for those roles as well. So yeah, really centered around understanding the healthcare landscape, understanding the resources available, and understanding how to have that exploratory conversation and navigate the resources with that client, making sure that the client or that individual is supported throughout the process. So those are some of the core characteristics of link workers.
Okay, so I would imagine this term's going to come up later on in the conversation. So it's good that everyone has kind of a clear picture of what the role of the link worker. So we got a kind of a good snapshot of what's happening on a national scale and a global scale. So I'm going to pass it over here to Suzanne. And so can you kind of give us some examples of what is actually happening in social prescribing in Newfoundland and Labrador by giving some examples?
Okay, thank you very much. Srija and Jane have done a phenomenal job of describing the big picture, the mid picture, and now we're to Newfoundland and Labrador. And I think that one thing that we need to note is that although there are common elements, there are also some, while there are similarities, there are some provinces, territories, some countries of the world which have a little bit of a different twist on social prescribing in terms of how they implement it. In Newfoundland and Labrador, we've chosen to use the term link worker, as you've explained, and as Srija has explained, that there's lots of different terms people use across the country. And so we use the term link worker. And in terms of social prescribing in our province, we've adopted an approach as part of a research project, and that's basically how we've started this. There was a collaboration between Seniors NL as a not-for-profit community-based organization who advocate for seniors and provide information and referral to seniors in our province and others, and with our healthcare system itself. So we are specifically working as a team, a collaboration, where we are now going to identify link workers. And we just recently did a call, and the competition just closed, so we'll be hiring 2 more link workers. In all, there will be 5 link workers in our province, and throughout the life of this project, which is 2 more years. And that in that instance, we will have each link worker they'll be housed within a family care team in our province. So there will be a direct contact, a direct integration of the link worker within that family care team as another member of the family care team. What will happen then is that, Srija just did a great job of explaining like what the link workers' roles will be and what kind of person they will be, what kind of a person we're looking for. We're not necessarily looking for somebody who comes from a regulated profession, although they can. And we want a special kind of person who's interested in what that person wants to say, what will bring joy to their life, how they think they can resolve and address some of the challenges they have in their life. And then another big piece of this is that link worker will be an active listener. They'll understand and appreciate some of the challenges the person has within the context of where they live in our province. And then they will be able to collaborate with the other team members if there are more complex situations that are happening that need to be, kind of related back to whoever is doing the referring. And then the other piece is that the link workers will actually assist and support the individual who may be a patient, maybe called a patient or a client. It's an individual who, in fact, who is over the age of 50. That's our goal here. and they will actually do a little bit of hand holding in terms of helping them, move forward. And I think another point that I'd like to make, which hasn't been brought up yet, is in Newfoundland and Labrador, we've decided to also acknowledge that the social determinants of health are very much embedded into social prescribing in terms of how we address those social determinants of health. And I especially wanted to mention, I think Jane just mentioned about in Japan, in terms of a minister of loneliness, that in fact, loneliness and social isolation have a huge impact on our health and our physical and our mental health and well-being. And social prescribing is an amazing tool in terms of trying to address some of that as well. Let me think what else. We have a committee that we've struck. We were very fortunate to receive funding from a not-for-profit organization, a foundation. And, it is a 3-year project. And I tell everybody that I think that our role is to develop social prescribing within the context of Newfoundland and Labrador, to implement it, to evaluate it, and Quality of Care NL has accepted the role of being our primary evaluator here, as well as other members of an evaluation team, of which Jane is one of them. And then I also like to say that we're not only going to do that, but we're going to implement social prescribing into our healthcare system itself. So just like in the UK, it becomes an embedded part of our healthcare system. Let me think what else. So we have an excellent team of people, and we are moving forward, and hope to update people as we go along.
Excellent. Sounds like a great project, and I've been on a few of those calls, Suzanne, and you've established a fantastic team across the province, who are highly engaged in this topic. I got a few more questions for all of you, but before we move on, I'm going to ask Melissa whether or not there are some questions that are coming from the audience.
Yeah, sure. Let me just bring these up here. One question that I think will lead nicely into the next question that you have on your list, Robert, is how do we support horticultural therapy opportunities as an integral part of our community healthcare system? And I feel like Jane might have her hand up to answer that question.
Yeah, I mean, I don't have exact ways in which that is going to be integrated within Newfoundland and Labrador, but there is a lot of use of horticultural therapy, gardening, time in nature being used in lots of different countries. The UK has a lot of programs related to that. Some of those take place in community gardens. So social prescribing is part of, or community gardens are part of the social prescribing. People are being prescribed time in nature generally, and Canada does have a Parks on Prescription program, which isn't horticultural therapy, but it is recommending that people spend time in nature, and any registered healthcare providers are able to prescribe time in nature and give a patient a parks permit. So I think that the current rules around that is that a healthcare provider is entitled to one of these each month to give to patients, and those then last a year. And so time spent in nature, I think that the idea with a lot of these gardening and time spent out in nature, that there are all sorts of different benefits around that. One is a social aspect. And so as Suzanne talked about, loneliness and isolation, which is such a concern at the moment for a lot of people, that people can spend time outside in a garden together, whether it's their own garden, community gardens, or programs set up within, for example, a botanical gardens. And there's a really interesting program in the UK that's part of what's called the Eden Project, which is a botanical gardens and has biomes. And they started a program there within the gardens for people living with diabetes. And then they ran a research project over there, and they had really interesting findings from that project with all sorts of different improvements on people's health as it relating to diabetes. Similar programs for people with COPD and heart disease. So that's a sort of quick response to that.
That actually answers another question that someone put in the chat. Have you seen social prescribing used to target specific health outcomes? Two examples that you just mentioned. The comment came from Roberta. She also shares, as one example, older adults with high nutrition risks. A study by Mills et al. Used data and identified lower levels of social support and social participation were associated with the development of high nutrition risks. So she was interested in hearing any other studies that you're aware of from around the world.
There are actually a number of studies that look at the use again of community gardens, where they're used not only as ways of improving health through the gardening, but also in producing food. And some of these programs are set up actually at GP practices in the UK. And so they draw on people from the entire practice, not just people who are being part of social prescribing. And so some of the physicians will take time to go out into the garden. But the idea there is partly that there are benefits from the actual gardening, but also that if people are growing their own food, there's more of an incentive to be eating vegetables. And also, it's trying to look at some of the inequities around healthcare, that it's allowing people to have much more affordable access to freshly grown and locally grown food. And I mean, within our own province, there are lots of community gardens all around the province, which again, within the context of social prescribing, could become integrated into that, rather than as being seen as something that's separate, just as a community venture, which is wonderful, as something like that, but it could actually be seen as beneficial to someone's health. And then it takes on a whole sort of new life of its own, and how people view that activity.
Is there any more questions from the audience, Melissa?
There are a couple there, but I think we can continue with yours, and we'll come back to those.
Sure. So, I mean, Jane, you touched on a lot of the health and well-being benefits of, being socially prescribed within the arts and within nature. Is there anything you'd like to add to that about the benefits of such social prescribing methods?
I think, since I didn't mention anything about music, and that's my background, I would like to draw attention to the role that music and the arts generally are playing within social prescribing. I'm involved in a project with Singwell, which is based in Ontario, and we will be doing a project in a community just north of Toronto, which is a social prescribing program for people living with COPD and other lung disease, and it's starting a choir for that particular group of people. And there are lots of choirs around the world which are using singing to promote better well-being, and that can have psychosocial benefits, cognitive benefits, physical benefits, emotional benefits, and there are lots of studies to support that now, with changes in hormone levels as a result of singing together or playing music together. And that can be in informal settings, so people getting together with friends, or it can be in more formal settings. And again, relating to one of the earlier questions, some of these are for targeted groups of people, so people living with dementia or living with Parkinson's or living with COPD, and there are singing and dance programs for all those groups of people. But also it can be the benefits that people can get from participating in a community group, whatever sort of music making it is, and then getting the benefits from that. And that's one of the things that I think that we could be doing more with, sort of engaging with community organizations, so that they can promote not only the fun aspect of singing together or playing music together, but that it actually benefits people's health. And then it becomes something that Daisy Fancourt, who wrote a study for the World Health Organization about the arts and health said that we shouldn't be thinking of the arts just as an add-on, but we should be thinking of it as being integral to our health. And she uses the analogy of the idea that we're supposed to eat our, well, however many fruits and vegetables a day, that there's the thinking around that. We should be also getting our arts component each day or each week to benefit health.
Thanks. So, Susanna, I'll pass it over to you. And I'll ask you, do you think that social prescribing in Newfoundland and Labrador can and will the pursuit of the population for better health and well-being, do you think social prescribing will work?
I feel confident that yes, it will work because I think it's intuitive. It's intuitive to all of us that this is a good thing. We found that during COVID and even prior to COVID, but certainly during the COVID experience, that it has been a profound sense of social isolation amongst people. In Newfoundland and Labrador, we all understand and appreciate the fact that many families have become very, very small and insular because their children have moved away. So many older adults have often depended on the community, in terms of connection and contact. So I think we've got to go back to some of those types of ways of thinking instead of always now focused on, if we're not feeling great, then we go see our healthcare provider, and our healthcare provider is trying to determine where from here. And I think these link workers can really help to support the rest of that system in terms of identifying how we can move forward with that, how people can react to that. I mean, health and well-being, we know that in our province we have a dismal record in terms of the state of our health and well-being, and that's fact. That's reality. So I think that other ways of looking at how we can improve our health and well-being, whether that's through a community garden or through a knitting group or through becoming a volunteer. There's all kinds of ways that we can do this. Previously, I should have noted that, of course, we've always had some form of social prescribing in our province. We never called it that, but we certainly have had every discipline, every professional group has always had some part of the role they play in terms of referring individuals to non-clinical kinds of services and supports. But this is going to be a really concerted effort where we normalize this term. We'll normalize the concept of yes, non-clinical kinds of supports. Whether it's a part of a singing group or part of whatever it is we choose to do, whatever gives us joy. That certainly is a legitimate form of improving our health and well-being. And hopefully people, and I have met a lot of older people in recent years, last couple of years, who are still very nervous and concerned about even leaving their homes, even about going to the supermarket and chatting to other people and certainly, being part of a group. We certainly have groups in our province. We have our Seniors NL, which, accepts phone calls and makes referrals. And this project that we're implementing will have a huge relationship with Seniors NL in terms of accessing that information. But we also have 50 plus clubs around the province, 130 of them. And that's exactly what they do. They bring together groups of seniors. They have different emphasis on terms of the nature of their groups, but often and most times coming together is the big issue, and sharing and education and knowledge and having fun. So I think that I think intuitively we know that social prescribing will be a positive influence on people, but people have to accept it as a part of our healthcare system. I think that's important.
Right.
And also we have to acknowledge that it is an integral part of our health and well-being.
Right, and you mentioned that the province has poor health outcomes, and that evidence laid the foundation of the health accord, and a lot of those actions are taking place as we speak. And so, like, obviously, those issues are not unique to the province you know, poor healthcare systems functioning right now. So I'm going to kind of pass it over to Srija, and just kind of on a national scale, does our system have the capacity for social prescribing, and who pays for it?
Yeah, and it is no surprise that Canadian healthcare system faces so many challenges, and integrating social prescribing into existing practice, it will require a lot of considerations of capacity, but there is capacity. There is capacity to integrate social prescribing. And if there is one thing that we have learned during COVID is that our healthcare system is very strong and we are adaptable. We can pivot. So when it comes to healthcare provider and community capacity, folks have been very, very creative in terms of building capacity within their existing area of work. Like I said in the past, sometimes social work, you will see a social worker assuming the role of a link worker. A lot of the times there are volunteers who have been trained to become skilled link workers. So yeah, like I said, there are existing capacities, and sometimes we are very, very creative at building capacities too. With all that being said, funding is also very important, and it is very, very critical to consider how we can build new initiatives while also considering how can we sustain these initiatives. So there are a couple of factors that contributes to that. So when we're thinking about a couple of things when we have to think about funding is that public and private partnerships. So collaborative efforts involving government agencies, healthcare organizations, philanthropic foundations, and private sectors can pool resources to fund social prescribing programs. The other thing is health systems integration. So integrating social prescribing into existing healthcare structure and funding models can optimize resource allocation and streamline ways of expenses. And there's also evidence of cost effectiveness. So demonstrating the cost effectiveness and long-term benefits of social prescribing through research, through pilot programs can also attract funding from healthcare payers and investors. So one of the things we were talking about today is about the impact of social prescribing on individuals' health and well-being. There is another set of impact, which is impact on the healthcare providers. How does social prescribing impact healthcare provider burden? So if we have evidence from pilot studies showing that it becoming a part of social prescribing pathway did influence their visit to emergency room and things like that. There are also decreased hospital visits too. So how can we showcase more of these benefits to just to make sure that we have funding for social prescribing? Yeah. So right now, social prescribing is funded differently in different provinces. So for example, in BC, social prescribing is funded through their ministry. In a lot of the other provinces, social prescribing is funded by a combination of different types of funders. So a combination of private foundations, philanthropic organizations, and government initiatives as well. So it is a combination of a lot of things. So yeah, if you're thinking about funding, look into your provincial funders and see alignments in their visions with social prescribing, specifically in the area where you want to advance social prescribing. Identify opportunities for collaboration, whether that is collaboration with communities or collaboration with primary care providers. All collaboration is always a very big strength, and see how we can elevate the existing capacity. There is capacity. How can we elevate that? How can we bring that up and make that more strong? All that to say, while there's challenges exist, the Canadian healthcare system does have potentials to embrace social prescribing, to build capacity for social prescribing.
Right. I mean, it's really about leveraging resources that already exist, and you know, bringing the social sector, the community sector, the health sector, you know, kind of coming and working as one for this to kind of function fluidly. Before I move on to my final question, I'm going to pass it over to Melissa again. And Melissa, is there any other questions coming from the audience?
Yeah, we have a few. Adam asks, what do we need to do to prepare health and social care providers from all different backgrounds to be part of a care system that integrates social prescribing? That could be open to anybody.
I think that ensuring that a very comprehensive understanding of what social prescribing is you know, in a very simple way is essential, not just for the healthcare system, but for the general public. And I often like say it's about normalizing what this is all about. This is not anything special or unique, or just all of a sudden it emerged. It is something that we've been doing, but we haven't really been paying much attention to how we're doing it. Therefore, it hasn't been implemented and really appreciated, I think, as much as we can. So, I mean, one of the things I plan to do, and I'm doing it already, is talking about social prescribing to as many groups as I can. And that means having presentations to the family care teams. There's lots of amazing, phenomenal webinars online that people can access. The Canadian Institute for Social Prescribing and some of the various provinces and countries of the world have been developing information. So there's all kinds of different ways, but it's about ensuring that our healthcare system and our general public themselves are knowledgeable.
Thank you, Suzanne. Another question from Joy. Individuals living with serious mental illness have been identified as a population that receive great benefit from social prescribing. Will that population be included in the Newfoundland and Labrador program? So obviously our discussion has focused a lot on the senior population, which is another group that has experienced great benefits from social prescribing, but perhaps we could touch a little bit on other groups of people who would benefit greatly from this type of initiative.
We've already had input from a variety of different groups of people who've expressed interest in that very issue, that social prescribing could be, an important approach that could be used. In terms of Joy's question about people who live with mental health challenges and issues, right now, anybody over age 50 who are members who are attached to a family care team can either be referred to a link worker or they can self-refer. So I think that regardless of what the health situation is, anybody can be referred as long as they demonstrate that they may be somebody who could really benefit from a resource or support that's identified through social prescribing. We've had fee-for-service physicians offices who've said, this could be a really good thing. So that's somebody else. And we've had community support or the community support services who've said, yes, this could be a really good thing here too. So we do know we've got social navigators in our province who are doing a little bit of this, just like Seja just referred to. And I think that as we go on, we'll see that this is going to have a broad impact on a whole bunch of variety of different groups and types of people.
Thank you, Suzanne. Heather asks, how is social prescribing different from, or how does it complement therapeutic recreation?
I can try to answer that. So we have been working with therapeutic recreation folks for some time as well. So how I have seen how they envision social prescribing is them being a prescriber and also playing the role of link worker. So they can play both roles. They can be the identifier to when you have a client coming to you and talking about their health and well-being, you can identify, is this a person who can benefit from other initiatives outside of therapeutic recreation. So that is a role that therapeutic recreation can play as an identifier. At the same time, you can also be the person who is the connector. You can connect them with therapeutic recreation programs and other programs. And you can also be the person who is providing therapeutic recreation services for your clients. So yeah, I think all that to say is that there is role for therapeutic recreation and social prescribing, and it really depends on where do you want to scale, where do you want to advance, and what do you think makes the most sense depending on the need that your community or your region has. But yeah, there's obviously so much potential and there's so much strengths in therapeutic recreation and social prescribing.
Maybe can I just add something there about music therapy as well, that music therapy is a clinical practice, and so in some ways comes outside of the scope of social prescribing. But in many places, music therapists are part of social prescribing schemes. And so, for example, in the UK, the British Lung Association runs a lot of choirs for people with lung disease, and a lot of those are run by music therapists, and they are part of social prescribing schemes. And so there are many ways in which people have been quite creative in the ways in which they're utilizing existing services, and they then become part of social prescribing. And I think that's something very similar with the therapeutic recreation as well.
And I think we should note that one of our social our link workers, one of our link workers, in fact, is a recreational therapist. So there's definitely an interrelationship between a number of different, professional groups and their usual activities. And part of those activities are often social prescribing. So it's, there's definitely an interrelationship.
Thanks. I'm just mindful of the time right now. Melissa, we probably have time for, maybe one or two questions if there is from the audience.
Yeah, sure. I just want to share a couple of examples that some people have put in the chat throughout our discussion. When we were talking about music therapy, someone referenced the Growing the Voices group, or Festival 500, who often do instant choirs, which I guess are almost like pop-up choirs, and programs like that. And another person shared, they're joining us from Manitoba. They said that in Manitoba, they have roles called cross-cultural mental health specialist, which introduce, navigate, connect, and facilitate, in addition to the clinical aspect, a cultural understanding of and bridging the work between communities and the formal mental health system. They said that they're currently in that role and they find it very rewarding and useful, and feel like they're making a difference in the system in Manitoba. So there's certainly, this goes back to what we mentioned about the different types of roles, the different names for link workers that people use, and different areas of focus. This one's focusing specifically on mental health. One other question that we have, do you already have community partners to whom people are being directed? So I'm not sure, Suzanne, how, and I guess, as we said, social prescribing is happening here, just not necessarily in the most formalized manner. So is part of your project to compile a list of resources and community partners and places to refer, that your link workers would refer clients to?
So one of the benefits of having a collaboration is the fact that the collaboration is between a not-for-profit organization, Seniors NL, who has an extremely robust inventory of what kinds of services and programs are available to seniors in our province. So while this project itself may be reaching out through five link workers working through five family care teams, everyone else can still automatically contact Seniors NL and ask for information. It could be anything from how can I get a bus pass, or is there a reduction? How can I access income tax? How can I, how can I access housing? Some of the questions that are asked already on a continual basis at Seniors NL are very much all about some can be really complex, is what I'm trying to say. Some can be really complex, while others are very simple questions. It's just information that people need. So that's already in existence, and that inventory will be there. We also have 211 in our province, which is a relatively new thing for Newfoundland and Labrador. And there will be a collaboration, of course, between 211 and Seniors NL, because there's already that very robust inventory, and they're both using the same platform, which is called iCarol. So yes, there's certainly, And another thing that we'll be doing is where these family care teams are located, we'll be ensuring that there may be even more specific resources and supports that could feed into that information and referral system, so that we continue to grow that and have access to that so that people can get that kind of information.
Melissa, if I may add to what Suzanne just said, I see that we have folks from across Canada here. So I wanted to let you know that on our website, socialprescribing.ca, we do have an initiative map for social prescribing, which is basically a map of the various different self-identified social prescribing initiatives that are happening across Canada. So there you can put in your address, and it will help you identify the closest location where you have some sort of social prescribing initiative happening. And you can also filter that through, the kind of initiative that you're looking for, the kind of focus population you're looking for. So there are resources on our website where you can identify these opportunities and initiatives in your area as well.
Thank you, Srija. Robert, I think we can squeeze in just one last question before your
Sure.
final one. Someone in the chat asked if there was a plan in place to measure who is benefiting from these social prescribing services, in terms of, the demographic, their geographic location, their previous access to healthcare. And Suzanne, I believe you mentioned that your research project has engaged with quality of care and else. So perhaps Suzanne and Robert, you could touch on how you're planning to evaluate that 3-year project.
Do you want me to go first, Suzanne? Is this a conflict of interest as the host?
No, you go right ahead, Robert.
Well, I mean, we're still kind of getting our feet wet on the project right now, and once the protocol is established, we're trying to aim for, we've mentioned it many times, and Melissa mentioned it at the very beginning of kind of mimicking the outcomes of what a learning health system or learning health and social system is trying to achieve, which is the quintuple aim. So we're aiming for that, and there's a lot of metrics and that we're trying to sort out of what we're going to use to measure some of these outcomes that are, of health benefits, financial benefits, of course, quality of life, which is a huge one, those sort of benefits. So within the near future, we'll have some answers of the actual metrics, but yes, there is a plan in place for the evaluation of the Seniors NL Social Prescribing Project.
So this project does have an advisory committee, and the advisory committee, the evaluation subcommittee also reports to the advisory committee. So we're constantly, reviewing and exploring, how we can best gather this information, because at the end of the day, we want to demonstrate and show that social prescribing is something that we want and we need in our province. So yes, in terms of the question that was asked, yes, there is a plan in place, and we're continuing down that path.
I can't get the idea of this flash choir coming together. Can you remember that fad that was years ago where these mob dancers used to get together? What was
A flash mob.
A flash mob. I'm not very hip, so. All right, I have one more question. I know, Srija, you kind of answered some of these, but this goes to everyone. Where can healthcare providers and patients find some resources on what social prescribing is?
Well, we are, just to reiterate a little bit of what I said, we do have a resources page on our website, and that is not just for resources that comes out of Canadian Institute for Social Prescribing. That is a resources page for everything that comes out across Canada about social prescribing. So anything that can be supportive of the implementation, or even just learning about what social prescribing is and how do we talk to primary care providers, how do we talk to general audience, what are some of the, so for example, at CIS, we're building some tools to understand what does the role of link worker, what can the role of link worker look like, what kind of curriculum do we have to have in terms of social prescribing capacity building. So yeah, all those resources, we try our best to showcase those on our website, so please visit that. We do have our social media platforms where we also try to showcase all those resources, anything that comes out of across Canada and internationally as well.
Thank you. I don't know if Suzanne or Jane, do you have anything to add for any resources?
I think one of the first resources that well, I think all you have to do is Google social prescribing and you'll find lots of information. I think one of the first resources that I explored was through the World Health Organization, and they've done some excellent work in terms of helping us to understand better, in terms of training and education, and of what social prescribing is all about. Here in Newfoundland and Labrador, we're at such, I mean, we've only been in existence for 7 months and we've already accomplished a lot. But I think it's very clear to us that we need to have, a social media presence. We need to get information out there, do presentations, do things like we're doing right here today, and get that message out there in terms of what social prescribing is all about.
Yeah, and I know Jane, I know you lead an interest group within Memorial University. I don't know whether is there a link that we could perhaps share?
That's a student group,
Okay.
and it's if you I think they have a social media presence, and it's the Canadian Institute of Social Prescribing Student Collective is
Okay.
the name of that group. And then medicine has a special interest group as well, which is open just for medical students. But that student collective is open to any students from any discipline, and it is multidisciplinary. And they're doing some really interesting work and are really engaged with learning and promoting the idea of social prescribing. I would just add for a web page, if anyone's interested in the idea of green social prescribing and the Parks on Prescription, that if you Google Parks on Prescription Canada, I think it's parx.ca or something similar to that. They have lots of information, not only on how to prescribe, but they have information for patients and for healthcare providers. And it's an evidence-based web page. So they link to lots of different articles all about green social prescribing. So it's a really useful web page for anyone interested in nature on prescription.
Perfect. Thank you so much. And thank you to everyone here online for joining us for this great discussion on social prescribing. So without further ado, I'm mindful of the time. I'm going to pass it over to you, Melissa, to close it down.
Thanks, Robert. So yeah, that's all the time we have for today's discussion, but I want to thank everybody who joined us online to listen and participate. There was lots of stuff coming in on the chat, and we shared a lot of links out to different resources that hopefully everybody got a chance to explore or save. And a special thank you to Srija, Suzanne, Jane, and Robert for leading us through this discussion today. Just a reminder that the recording of this session will be up on our YouTube channel in the coming days. And you can check out the recordings of all of our previous Healthy Discussions webinars there as well. And lastly, you're going to see a very short post-event survey on your screen after we end the webinar. We'd appreciate you providing any feedback or ideas for future Healthy Discussions. So thank you again, everybody, and have a great day.
Thank you.